Get into the panel itself, I did want to make one important note or correction to our program, and that is that Ms. Sandra Hernandez is actually the president and CEO of the California Healthcare Foundation, not whatever job she was randomly assigned to in the program. So maybe, I don't know, maybe she moonlights, I know, maybe she moonlights for a little extra cash, I just don't know. But we are very excited to have our whole panel here with us today. So actually, if I could ask our panelists to join me up here on the stage, that would be great. I will say that all of these panelists were really dancing just 5 minutes ago. I was very, very impressed with that. Yes. Yes. I definitely saw a lot of enthusiasm from the middle to this side, so we're going to have to try that again later in the day and see how the left side of the room does. Okay, so what I would like to say here is that moderating our panel is Kiran Chetry. She serves as both anchor and reporter for CNN and Fox News. Kiran is a storyteller at heart, and she brings an inordinate amount of passion, energy, and expertise to these topics that we're about to hear on. Given her role as moderator, she wants to try to restrain herself somewhat, but I'm not sure if she can do it, simply given how fired up she gets about these different topics. So we'll have to see how she does as we kick off this panel. Thanks. Kiran.
Thank you so much, Jody. I have to tell you guys, the dancing was really unexpected. Now, Pronoy and I have been working together, coordinating this happening, and he told me that we were going to have these dancers, and he was so excited about it. I did not know that you all could boogie, though, too. And I have blackmail pictures on my iPhone. No, I'm kidding. Thanks so much for joining us. I know we have we had an early call time today, panel-wise, and you guys were here yesterday as well, but I find it very fascinating to be able to get a chance to introduce and then and get to actually hear some of the expertise and some of the ideas from all four of you. So thank you so much for being with us. Pronoy, I got to know very well. It's interesting, we planned to have me moderate this panel before the Nepal earthquake actually happened. And we were going to talk about disaster relief on the global level briefly and talk about other things as well. After the Nepal earthquake hit, I was born in Kathmandu, by the way, and my father is a native Nepalese, and my mother was an American Peace Corps volunteer, and that's how they ended up meeting, and that's how I became born in Kathmandu, Nepal. And a lot of my cousins are here in America, but a lot of my father's brothers and sisters, and some of my cousins still live there, so it was a terrifying experience, and I immediately tried to link up with a few charities that were already on the ground and new local leaders in the healthcare profession and cut a couple of PSAs. And we ended up talking briefly about how our panel, which is about the common good, and dovetails into exactly what happened in Nepal. When I think about the innovations in healthcare, the sheer logistics of, you can have money and you can have the right spirit, but the sheer logistics of trying to get to Nepal, especially after a disaster. I mean, on a good day, their airport's not the easiest to get in and out of, let alone when this happened. So we are going to talk a little bit about that, as well as other more pedestrian, I guess you could say, ways that innovation and technology is changing the way that patients are cared for and the way that communities try to serve their people to be as healthy as possible. I want to introduce the panel. So Pronoy Saha, correct? You got to get it right. Okay. He, of course, is the head honcho of this whole thing. But even last night, his passion was amazing because I mean, this is your area of expertise in your field, but he was so excited by what some of the ideas that came out of the various panels yesterday. And I don't know how he could be excited about anything given that he's been working tirelessly to get everybody here. And so he brings a real passion to get together like-minded people who have thoughts and innovations and find ways to learn from each other instead of not necessarily compete, but to learn from each other and maybe get some ideas that can be employed. Also, Christopher Kunney is joining us as well. He said, you don't have to read this whole thing. I said, I don't understand what half of the initials are, so don't worry, I'm not going to. But he is the executive healthcare IT strategist for a company by the name of, hold on, I have her here, I'm sorry. It's
Infinite Options.
Thank you. I had infinite options to choose from when looking at your bio. But basically, they're a healthcare IT company, and they work with firms as well as organizations to try to maximize strategies that make it easier and add more value for the dollar. You can explain more if you would like to. We also have with us Dr. Hernandez. We had to do a correction, correct? Dr. Sandra Hernandez. She is currently, right at this time, you actually do wear many hats, though, because you're still an assistant professor at UC San Francisco School of Medicine. In addition, she's the CEO of the California Healthcare Foundation. That job started in January 2014. And basically, they are headquartered in Oakland, California, independent foundation. They have $700 million in assets, and their mission statement is that they are dedicated to improving the health of people in California. So we're great. It's a great honor to have you here as well.
Thank you very much.
And last but not least, not only can she boogie, she is responsible for a big region. They call it District 9. She is the regional director for the U.S. Department of Health and Human Services, and this includes all of California, Nevada, Arizona, Hawaii, Guam, and the outer Pacific Islands. Do you get to go to Hawaii, by the way, as part of your job?
I've been on the job 6 months and not yet.
Not fair, right? But before you were doing that, you were also the CEO of the California Association of Public Hospitals and Healthcare Systems, 8 years in that position as well. And as you can tell from the panelists, they're smart and they have a lot of ideas. So welcome, everybody.
Thank you.
Now we're going to be sharing a microphone, so I think we lean in a little bit. But
we can share. Yeah, we can. Yeah,
are you sure?
Yeah.
Okay. Sure. Oh, is that the wireless one? Yeah, let me grab that so everybody doesn't have to feel. Sorry, I don't want everybody to feel like they have to lean in.
Sure.
We have enough to worry about. Thanks so much. Okay, so the first thing I wanted to ask each of you before I ask more specific questions is why you're here at the conference and what you view as some of the biggest challenges facing healthcare as you and what you wanted to learn and talk about as you came. So can I start with Melissa,
Sure.
please, and just explain a little bit about from your vantage point what you think some of the biggest challenges are.
Yeah, I think, good morning, everybody. Thank you for having me. I'm happy to be here. And I loved the dancing myself. It's my second time dancing at a conference in a week, so I must be, on a roll here.
Yeah.
I'm going to the right conferences, Sandra says that's right. Well, the reason I really wanted to be here and appreciated the opportunity is that as we look at the implementation of health reform, we're clearly making progress on building a foundation of coverage. More than 16 million people have gained coverage under the ACA that did not have it before. But that is really a first step. The end goal is not just to have coverage. Building on that foundation of coverage, the effort is to get people connected to the health care that they need. And ultimately, the purpose of that is to improve health of individuals and communities. And I was very interested in being here to actually hear some of the ideas both from my fellow panelists but also from the audience about how you see technology working along that continuum, particularly at the level as we focus on health status, how you think we can engage patients and communities in that process of improving not just health care, but really the health overall of where they live and of their own individual health. And I think there are a lot of really exciting things happening at both the individual and community level in terms of that engagement, and it seems like there might be some important roles and capabilities that technology brings to that. So that was really my strong interest in being here. In terms of challenges, well, gosh, there are many in healthcare. I mean, we are in a complete fundamental change in healthcare. In every aspect of the healthcare system in the United States is impacted by reform and impacted by trends that were happening even before the ACA. And so I'll briefly mention a few things, and perhaps we'll get into discussion of a few of those. Clearly, we need to continue to work on the issue of affordability. We've made very good progress making health insurance more affordable for consumers through the Affordable Care Act. We have to keep our eye on the ball on that, continue that effort, and not just on health insurance, but to work on the issue of the underlying cost of healthcare. I was with a large health system for a couple of hours yesterday afternoon who's really been working on this issue of getting the waste out of healthcare, really completely starting from scratch, transforming all their processes of care, and actually has achieved bending that cost curve of actually getting tremendous amounts of unnecessary cost out of their system and out of the way they deliver care. So we have work to do on affordability and cost. I think that's an ongoing challenge. I do think building on this foundation of coverage, a challenge is really partnering with consumers so that they're choosing a health insurance product that's right for them and for their family, and then also utilizing that care to work with them on whatever healthcare needs they have, particularly for those with chronic disease. And then there's a whole body of work, of course, around we want to bring more people into the health system, but we need to make our health system better. And we know we can do that. We have ways we know we have ways, and we need to improve how we deliver care, the quality of care, how we spend our healthcare dollars, better spending so we're really paying for value and not volume, and that we are focused on having the way we deliver care and the way we pay for healthcare focused on that ultimate end goal of improving health status. So that's a lot to chew on. I'll leave it at that for now. Thank you.
Thanks so much. Dr. Hernandez?
Thank you. Let me build on that. California Healthcare Foundation, as was noted, is a statewide foundation. And typically you think of foundations as doing grants and piloting different ways to improve primary care access, to improve specialty care access, to improve care efficiency, to improve patient navigation. And there are a lot of ways in which health foundations through grant-making programs seek to do that. One of the things the foundation learned many years ago, about 5 or 6 years ago, is that those pilots tend to end when the grant funding ends. And so we began to think, living here in the Bay Area and in Silicon Valley, there were so many entrepreneurs that were beginning to think about how to positively disrupt healthcare, to improve primary care, to improve the transitions between acute care hospitals and being discharged. And so the foundation about 5 years ago developed a program of program-related investments, which are really early-stage loans to companies who have a disruptive technology, generally speaking, a technology that can potentially scale to a large population of low-income folks who might be in a Medi-Cal program or might be served by community clinics or might be served by rural hospitals or might be served by county hospitals. So that delivery system we typically think of as the safety net system. My colleague to the left here did a lot of work with public hospitals in that space. And so what we did was begin to look at companies through the lens of, do they have a disruptive technology that is scalable and that could be applied for low-income patients that are now increasingly enrolled in Medicaid through ACA. Step back for a moment. 1 out of every 4 Californians today is eligible for the Medi-Cal program. That's a program that has been served historically by a safety net delivery system that typically does not have capabilities to try new innovations. So the foundation really works in 2 ways. We have worked historically to support the safety net to improve its capacity and its efficiencies and its operational capabilities. And now working with companies who have something potentially to deliver in that space, to make those introductions, to provide grants, and to provide early investments in those companies. We've developed a portfolio of about 9 companies. And we're here today because we want to continue to learn about new disruptors and new ideas, as well as to understand what problems need to be solved so that as innovators come up and try to think about solving those problems through new companies and new capabilities, we can also learn about how we can incorporate them potentially in the portfolio. So I'll talk a little bit more about a couple of those case studies, but that's why we're here, and we're excited to both learn and share.
Thank you so much. And it's interesting because you're talking about wanting to learn more about companies that could do that. Christopher, can your company do it? To explain a little bit about how
Infinite options?
Yes. I know infinite options now.
Okay,
How you would characterize what it is your company's trying to do and how that can be applied to some of the issues that both Dr. Hernandez and Melissa discussed.
Sure. So our firm, IO Technologies, or Infinite Options, is a healthcare IT management consulting firm, and we work with fairly qualified health centers, PACE organizations, rural hospitals, and providers, both domestically and internationally, to deliver effective technologies to help improve the quality of care for the patient populations that they serve. We work really closely with our clients to implement things like telehealth technologies. We leverage very heavily mobile-based technologies, mobile health, passive monitoring tools, and we advise a number of startup companies who are bringing disruptive technologies to the healthcare IT space. It is an exciting time, I think, to be in healthcare IT right now. And I think some of the biggest challenges with healthcare with healthcare in general, along with access, is patient engagement. And how do we get the patient to take more accountability for their care, to become more proactive in the delivery of that care as well. As we move towards this accountable care organization model, part of the challenge and part of the concerns many providers have is that there's only so much I can do to convince the patient to start living a healthier life, to take their medication when directed, and to be a part of this process, especially for those individuals who are also being an advocate for patients as well, too, mothers and fathers and senior citizens and others that folks are having to advocate for and support. And so we work really closely with our clients to find ways and solutions that will help the patient become more engaged in that process, along with trying to drive the cost out of the delivery of care as well, too, by the use of electronic health records, by leveraging disease registries, by implementing business analytics and clinical analytics that will help our providers make smarter decisions about the delivery of care. And I think all those things implemented in a very holistic way will have a huge impact on the quality of care going forward.
Thank you so much. And we're going to be talking about some of those examples. We were talking about examples of either innovations or programs that have actually worked, success stories, and we're going to get to that in a minute. But first, I want to hear from Pronoy as well. Thanks for being on our panel. You brought everybody really together with this innovation conference. What is the mission for your company, and what did you hope to learn or figure out different methods of potentially solving when we talk about common good?
Right. Thank you. So at Health Technology Forum, we dream about how to use social, global, mobile technologies to improve the healthcare of the global population, including California. We're in California right now. So what do I mean by that? Is that cell phone technology is very pervasive in the third world country and in poor community, underserved community, underrepresented community. Everybody has a cell phone and they have a smartphone, and the smartphone is coming with a lot of sensors. Cloud technology is very strong, and the cost is going down. So how do we build the scalable healthcare solutions that can be delivered effectively over the network to make people more connected to the health? What do we mean by health? Preventive care, primary care, healthcare education, including food and nutrition, And then other wellness. We are also analyzing here other wellness, which is yoga, dancing, we just danced, meditation, acupuncture, and healthy cooking. So these are the ways to make, we believe, this healthcare more sustainable. So we are analyzing how healthcare can be more sustainable, and that's why we're here. Another thing that we're going to talk about is the resilient community when adverse events like Kathmandu earthquake happens. What are the systems and community that can be placed ahead of time so we can combat those adverse events? Rich and poor, everybody becomes underserved at that time. So how do we build the systems to enable the community and the healthcare professionals and government officials to combat those effects more effectively? And that's what we're analyzing, and we're very proud that all of you came. We have 90 speakers speaking today and tomorrow. We are analyzing the use case of healthcare delivery and consumption and how technology, global, social, mobile technologies can help and close the gap between people who has healthcare and people who doesn't. And that's why you're here.
Well, thank you so much. And you brought up a good point when you talked about mobile technology. My parents are in their 70s, and they both have iPhones. It's a little crazy, you know, you're thinking back to the time where even when I was growing up, we didn't even have, our mobile phone was in a leather case underneath our car, only to be used in emergencies. Remember those days? And now there are ways in which people can communicate in ways that they never even imagined a decade ago. And if a 73 and 74-year-old can embrace technology, I think doctors can on local levels. I think that it's almost like trying to steer the Titanic when you deal in hospital systems and you deal with a lot of bureaucracy and red tape. And I don't mean it in a negative way. I mean there are certain procedures that have to happen the way that they happen for liability purposes and for other reasons. But that element that all of you discussed about patient empowerment, I think, is very important because you can lead a horse to water, ... And so people have to be invested in their own. It's not just, well, I've been assigned a doctor or I've been assigned a clinic. It's about learning how to navigate those types of systems so that you can protect yourself and your family, that preventative care is something that people don't have to go to the emergency room to get their blood pressure checked. And technology's advances have made huge differences for people like that. And when I was a reporter in Erie, Pennsylvania, we used to do a series called Medical Breakthroughs, and they would talk about things that were on the horizon that hadn't yet happened. And that was, I think, in 1996. And I just found some old scripts when I was cleaning out my attic and my mom's attic and basement, which I think she saved everything I've done, including finger painting in kindergarten, so had to get rid of some of it. But it was interesting when I was looking back at the scripts, how many of these things were a pipe dream in 1996 that now are just a part of healthcare. They were talking about being able to use titanium cages to almost mimic a spinal column, your vertebrae. Ways that a robotic doctor could do some robotic rounds and then send that information back to the attending physician. Things that we were thinking, there's no way a robot's going to be able to do that. And that's not a widespread use right now, but eventually a lot of those quote breakthroughs that were just pilot projects in teaching hospitals are now being used today. And that's why I think this is exciting. I think that there is a lot of redundancy, repetition, time being wasted that could help people. And all of you know that all too well, and that's why you're here as well. I think that a lot of the jargon, the nomenclature I'm not quite familiar with. But I understand, actually the only thing I do want you guys to clarify as well is talking about the disruptive technologies to improve the system. But I do want to briefly touch on the first thing that we were discussing, which was global response to disasters. How heavily do you think that we rely on technology when things like that happen? An earthquake in Nepal,
You could also talk about, let's say, a rescue effort. I remember the Chilean miners even. They needed to call on companies who had ways to do something that they had never done before, ways to figure out how to drill down in one area of the mine without hurting, how to get medication down there, and take mini cameras and be able to actually assess the men that were down there, and then appropriately respond. Some of them had chronic conditions like diabetes, high blood pressure. All of that was made possible, and those guys came out alive because of technology. And the world got to see it because of technology. When something like the Nepal earthquake happens, how does technology and innovation, the way that not only is the disaster explained to people and broadcast, but also how it is used in actually helping people in these types of disasters? Anyone can weigh in on that.
I'll take a quick stab. I think first and foremost, access to information. So the role that you as a reporter plays, the fact that we as a global community were aware that the incident actually happened in a 24-hour news cycle. It wasn't just, a momentary news story. It was a continuous communication about what was taking place in that region, which allowed the global community to rally behind this region and provide the resources needed to assist them in the recovery efforts. So I think just starting with just pure, communication and access to information allows us to get further engaged in the process. I also think, as you mentioned, the fact that, we have things like, electronic health records and technologies that allow us to get access to the patient's current condition. We can now be more proactive in assisting that patient. If we know someone is diabetic, we can make sure that the medication is delivered to them. If we know someone has recently gone through a surgery or had some other condition, we can be more proactive in our treatment and may not make a medical mistake because we're not aware of what their current condition is. So I think having that information makes it more creates a greater opportunity for a survival rate for a patient. And I think as we continue to adapt more passive monitoring technologies, like the Fitbit types of technologies where they become much more smarter, we can get that information again in real time. And again, that will allow us to provide a smarter way to deliver care to those patients as well.
So California Healthcare Foundation typically doesn't do anything globally, but I think there are some very interesting parallels. When you have a massive disaster such as Nepal or a major earthquake here in California, as an example, you do want to mobilize all sectors to be able to bring whatever benefits they can, whether it's logistics or medical supplies or the like. And it's really important to know, therefore, who is in your community and who is doing what. It is really very local. At the San Francisco Foundation, where I was before the California Healthcare Foundation, we did a lot of disaster response because donors would want to send dollars to Nepal and want to know where would you send them to have the most benefit. And the answer typically is organizations that are on the ground and have been on the ground before the emergency, precisely because they are there trying to build the infrastructure of a delivery system. And so if you're going to try to mobilize resources, you get a lot of information on the ground from technology, from organizations that have been in the community over a long period of time pre-disaster. And it does, as you think about building the infrastructure, whether it's for a major crisis or for infrastructure for an ongoing delivery system, you do need to think about the local people who are trusted and respected, who understand the culture, understand the language, and who can use those tools to push out information that then mobilizes resources from multiple sectors.
So what I will add to Sandra and you, Christopher, is this. We talked about the social technologies. The Twitter platform, Facebook platform, texting platform, and MMS technologies over the cell network. These are very powerful technologies, can be deployed by civic government and municipalities and federal government that can be monitoring on time and creating analytics from it. So these are some of the things that not being used yet, but I think is in the horizon, that we can use that to disseminate information to the people And how Twitter works is just a kind of a snowball thing. So, so that kind of technology can be really effectively used for things like earthquake or other natural disaster.
No, you're right. There were so many stories where people were texting saying, "I'm trapped here," and they were able to be rescued, which is amazing as well. That coupled with the actual ability to text or the ability to let people know where you are if you're in that, but also some version of the reverse 911, where people could receive texts, let's say, about if you're trapped, or it's hard to explain. Okay, if you're trapped in an earthquake, let's say, you text this, you text to this number, 344, sort of what a CVS pharmacy will do. Press Y if you want your prescription refilled, which they do now, or N if you are okay. But that some way for that to then translate into being able to pinpoint where that cell phone is. And I mean, this is obviously something down the road that might be difficult to have happen. But instead of wasting hours digging, with a limited amount of people and volunteers, you can find out how to get to a patient much quicker. I mean, that would be just one example of how the types of emerging technologies that are, even in Nepal, people can text. People have, Blackberries, Android, cell phones, iPhones. And that's made a huge difference, I think, as well, in terms of making sure it's the frustrating cycle of there's funding, there's actually, people on the ground wanting to help with a truck full of relief supplies, and then there are the people that badly need it. And sometimes there's such a disconnect that it just doesn't happen. We saw that a lot in Haiti as well. And bridging that gap is vital. Finding out how to do it best is, I think, the most challenging. Exactly. Melissa?
Yeah, I'll just add two thoughts. This is not my central area of expertise, but I have become more involved in emergency response because of the role I'm in right now. And there's two things I think that the federal government's doing that I've learned about. One is one of the things that the federal government and FEMA are trying to do more in a response is to share more quickly a lot of the data that they are receiving, both mapping and other kinds of data, and then posting it so that other entities that have the capability to do deeper analysis or match it with other technologies that they have can use some of the information the federal government has to help make a more effective response more quickly. So I think that kind of sharing and transparency and making that publicly available is something that we are trying to do. The other project that I've become aware of is something the federal government is not sort of the lead in, but that a number of organizations are doing that we are connected to, which is what actually each of the other panelists mentioned, which is really thinking about this work in advance, and which is to do much more detailed mapping of communities where there's not effective mapping now. And I don't just mean street mapping, I mean buildings and at what time of day or how many people likely to be there, so that we have a much more robust understanding of what the impact might be in areas that may not have current mapping available, so that when things happen in more remote places, there's actually been more work in advance to identify, is there a school there? Does it have 50 kids or 500 kids in it? And making that much more available in more remote places.
And that's the other thing that I wanted to ask you guys about as well when we talk about intention versus implementation when things like this happen. And it's not just a Nepal earthquake. Let's say California, because New York had this happen as well, there's an unexpected emergency that forces you to take dollars that may have been used for, let's say, a preventative program or free flu shots for seniors or whatever that may be, that has to then be redirected in New York. And I mean, I don't have my hands on the budget, so I don't know exactly. I know that states can apply for emergency assistance from the federal government when these things happen, that local communities can ask for aid from the state when certain things happen. But at the end of the day, you're still paying for it. Someone's paying for it. And in New York, they had the patient who came over who had to be treated for Ebola, and the hospital had never experienced it before. They're having to figure out how to make sure that no other patients that are currently there get it, how to treat the guy and make sure that he survives, and how to protect the workers involved to the tune of millions and millions of dollars. Those are the types of things that you can't necessarily predict. Same with natural disasters, fires, things that happen. And when that money gets redirected, does it take away from your core population that you serve? And how would technology potentially help those cases of unexpected disasters that are very, very costly in your communities, in your states, in your counties, you know, or even in a neighboring country?
Tough question.
I wasn't trying to stump you.
Well, I'll put on my HIV hat for a moment and tell you that when HIV broke out in the early 80s, if you just look at public health dollars and expenditures broadly, I was in the health department at the time, and you know, we were, you know, inches close from totally eradicating tuberculosis. And in the spirit of, you then have a very contagious disease of HIV, which at the time we didn't know was an antiretroviral. We didn't know it was a retrovirus. We didn't have any antiretrovirals. We were totally doing infection control. I mean, it was really pandemic circumstances. You do end up redirecting public health resources from one potentially the disease that could have been eliminated to address a major other outbreak. And in fact, we did not eradicate tuberculosis. And in fact, now we have overlapping diseases of HIV and tuberculosis in Africa and many other countries, and in some major urban cities in the United States as well. So it is true that there is a movement of dollars that happens when you have an outbreak like that. I do think Ebola preparedness in the United States is an important example of the question of how do hospitals respond to all kinds of things. Multi-drug resistant organisms is another new example. If we get a very aggressive bacteria that we turned out not to have any antibiotics to use, of which that would be a situation where sharing information, data exchanges across major urban centers, disease control. We now have technology that is much faster than it used to be to understand where the outbreaks are and how quickly they're happening. And there are opportunities there to use technology to get that information out in a way that's very useful to the public as well as to those policymakers who have to decide how to allocate resources to it. But I think there's a lot that we should learn from the HIV epidemic that apply to Ebola preparedness and to any other outbreak that we would necessarily need to do. Should note that as we think about getting more value out of healthcare, we're going to have less hospitals. Mm-hmm. And there's already a trend of hospitals declining because of resources in rural areas. And so the question around how would you respond to a major whatever, fill in the blank, an epidemic, a virus, a multi-drug resistant organism, really does require that you think about what the infrastructure design is for how you mobilize people to get what you want them to do when you need to do it. And we have many, many more technologies and tools today than we did early in the HIV epidemic, for sure.
I would just say, in terms of disasters that unpredicted disasters that occur, I think technology has allowed, as my colleague just stated, the ability to mobilize care a lot faster. And so now you can, in Nepal or in other places where you've had these major disasters, the ability to set up mobile hospitals in a very short period of time that can deliver quality of care, not only just ambulatory treatment, but acute care treatment. There are surgeries that are being performed in these mobile hospitals, and in some cases, long-term care of the patient in these facilities. So I think technology has allowed us and given us the ability to not to have to have in place traditional brick and mortar facilities in order to deliver care, that we can set up these facilities very quickly and deliver high quality care as well.
Along those lines, and you talked about the electronic medical records, and I see you two smiling because it is hard to figure it out, but I often wonder, I can swipe my CVS card, or we have a Stop and Shop is what they call our grocery store. When I swipe my card, they know everything I've ever purchased, for the past year, 2 years, however long. I get coupons based on my past buying history. Yet I go to the ER because I fell skiing, and they don't know anything about me at all. I'm being triaged, and obviously they're going to ask questions about the condition, but if I could have swiped my CVS card, but really my healthcare card, and immediately it would show, no history of thin blood, so if I'm bruised or bleeding or not allergic to these medications. Sometimes it feels like when one doctor or health provider cycles off of their shift and someone comes on, you're reinventing the wheel every time. That could be talked about on a response to global disaster level. So the next group that comes to Nepal is starting from scratch. They don't know where is the best place for us to ... Where is the best local staging ground for us to tell people to come to get MREs, or blankets. And so my two questions are: is it unrealistic that we eventually would be at that place where you swipe your card and people know what your history is and what's happened? And number two, almost like a Google share, like the Google document that everybody can edit, then it would be something along the lines of like the Nepal earthquake disaster response, and people would go in and write down, links, or here's where we stayed, here's where you can do this, and others can share it so that the time just getting your sea legs, so to speak, can be eliminated because of technology and because you're drawing on input that was easily inputted from somebody who's now thousands of miles away that was there before you.
So I would say absolutely not unrealistic to expect a day in which we are much better at sharing medical information at point of care. I think we are, if you look at the industry and all the work that's being done on sharing of electronic medical records and lifetime clinical records, we will get there. That said, as a physician who walks in every Friday to San Francisco General Hospital and sees AIDS patients and are converting from a homemade data system for all of our medical records to a new system who shall go unnamed, I can just tell you it is really hard work to do that, even when you are motivated, see the vision for it, want to do it, are motivated to do it. It is still really challenging. And in fact, one of the biggest obstacles that we have found in trying to take these innovative companies who have offerings, whether it's specialty care in rural areas or any of these technologies, the biggest challenge is really to get the attention of the delivery system, who right now is working to, by and large, adopt themselves to new electronic health medical records.
Wait, what was the first part of that? You said the biggest challenge is getting
their attention. I mean, you've got major delivery systems that are converting into new EHRs.
But when you're saying are you talking about
health records?
No, the electronic delivery
hospitals,
systems, meaning hospitals.
Hospitals and clinics and networks of physicians.
Okay.
So increasingly, we refer to them as ASOs, but essentially you're seeing physician groups and clinics and hospitals working together, and in some cases counties beginning to talk about whether they jointly adopt a similar electronic health records for patients who actually get care across counties. It's not like people just get care at their local clinic. Sometimes they go see a specialist here, or they have a family member in Alameda and they live in San Mateo. And so there is real ongoing work at getting electronic health records on board to be able to use the data analytics and do that information. It is not easy to do. And so one of the challenges that we have found in getting some of our companies adopted and their technology and tools adopted in the delivery system, in the safety net, is precisely that. They are working to do their electronic health records. And so getting the attention of IT and all the capabilities that you need is a competing against, why don't you try this innovation that will help you do that? And so I think we will get there, and the system will get there. The feds have tried to, design standards and incentivize folks to get on meaningful use and, put money in that. But I do think we are not far from a day when all of our medical records will be accessible on a chip in an ear. I don't know. I'm not the entrepreneur, but I will tell you that I don't think we're far from that. We are right now trying to get the infrastructure for which 30, 40 years we've not invested like we have in other industries. And so we are really on a very steep curve of innovations that are happening there. And I think we're not very far from the day we'll be much better about knowing all of that information at wherever your point of care will be.
I'd also comment. I think we're absolutely correct. I think we're right at the cusp of seeing that become reality. You just think about just 8 years ago, less than probably 10% of most healthcare organizations had, an active working electronic health record system, and just within the 8-year period, we have well over 90+% out there that are currently using it, both on an ambulatory side and on a hospital side. So there's been a tremendous adoption of these technologies. Part of the challenge with the technologies today is they're first and second generation. And so there's still a lot of issues around the workflow of the technology because, as you mentioned, as a physician, your goal is to go in and see a patient and focus on the patient, not necessarily have to focus on a tool to get information into a tool and try to see the patient at the same time. So we've got to continue to refine these technologies so it is easier for the provider to continue to see the patient and treat the patient and capture that information in a seamless fashion such that it doesn't slow down their time to see that patient and makes it difficult for them to navigate the information needed to make a smart decision. We also, you look at models though, and there are some successful models out there like Kaiser, for example. I mean, you can go literally anywhere in the country today and go to a Kaiser facility and they can pull up your electronic health record. They can get information about you. Some of the challenges exist in the laws that exist around privacy as well. Although Kaiser has the ability to pull your record up in any facility, in some cases they may be limited because of the privacy and security rules associated for a particular state.
I see people in the audience, so this must have touched a nerve. Some in the audience are saying no, and I know there's a debate about that very issue.
Exactly, and so although there's a huge adoption, there's still a lot of opportunity to refine these technologies and make them more robust so that physicians and clinicians can leverage them in an effective way. And again, just 8 years ago, many healthcare organizations weren't even actively using these tools or may not even have adopted them at that particular time.
Can I add a few of that? So as Dr. Hernandez said, the federal government has actually made this issue over the last several years a very significant priority in terms of providing funding and incentive payments for healthcare providers to adopt electronic health records and achieve meaningful use. And I do think we're really moving along that pathway. That said, there are a couple of issues I would raise that I do see a role for technology. One of them is I have the opportunity to visit with a lot of hospitals and physician groups and clinics throughout the region that was described, and most of the time when I do that, I hear about how for most physicians, and there was one yesterday, he had actually counted how many clicks he had to do in the course of a visit, and it was like 156 or something. I mean, it was some really crazy number. And I often hear that from sort of the younger physicians, they're like, why is this so clunky? Like, why? How come I can do some of the things you described and other things with so much ease on my phone, my mobile phone, but when it comes to this, it's just so complicated and clunky. And so my own sort of personal sense, I don't know that's so much the position of the federal government, my own personal sense is that there is still some technological sort of evolution that has to happen in terms of those products and how they operate to really be workable for clinicians in sort of a daily way. So there's sort of more opportunity there. And I would say the other thing is I do think the federal government has recognized that some of the standards and the way it has set the standards, the prescriptiveness of them has not been as supportive of achieving the goals for providers as we had hoped, and we actually have some rules out currently. The comment period ends tomorrow on a couple of rules where we are trying to offer a bit more flexibility and streamlined approach to meaningful use and interoperability and the EHR incentive payment. So hopefully we're making some improvements there. We're continuing to look at those issues. The other one that I want to mention that we have also been looking at within HHS is the issue of information blocking, and we recently provided a report to Congress that this is actually a real issue, and we still have work to do to get all of the entities that have health information that could be sharing it within the framework of what's allowable under the law to actually do so. And I think there are many issues that go into why that is happening, but just to note that I do think that that is a real issue. That's what some recent analysis we've done did find.
I have a quick comment on this. You mentioned national ID card to have health information. Everybody has credit card and do online banking, but when you get to healthcare, everybody's scared of using healthcare portal for your information. I don't know why that is. So that's one problem, is stigma that you have to overcome. And then some other countries are, although we are very good in innovation, we come up with new systems and technologies, mobile technologies, but some other countries are way more advanced in this area. For instance, France has a national card, can do exactly what you talked about, your CVS card.
You're going to get me in trouble by saying national ID card. That is
whatever, it's a health card.
I didn't mean
or
national
whatever.
ID card, so don't quote that. But I know
like
what you're
India,
saying. I know
country like India is introducing a card which can be used for exactly the same thing that you talked about.
Yeah, and
health record.
and
so
I did
on and on. So I think federal government maybe one day can create an ID system or some system that when you're born, you're given that social security number or whatever in the chip, and that has your information. And
okay,
that
I
will
see
simplify
people.
a lot of
You're right. I think that, but look, there are people who don't come to my house if you're the census. You're evil. And everyone has a right to their opinion about things like that. There obviously would be opt-out functions, but I personally think that we are kidding ourselves if we think that there's somehow this shroud of privacy around our health records, because I have to write my social security number down on the piece of paper, and the lady's busy doing something else, and it's sitting here with 4 other people's. Now, I mean, if I wanted to, I could reach my hand in the new patient arrival bin, take the other clipboard, and go steal someone's ID. I mean, we act as though there's this, that once we give up this information, we give up that information every day, pretty much. And I'm not a conspiracy theorist. I'm just saying that that the fear associated with that is one of the challenges. And I know we have the 5-minute warning, and I wanted to be able to ask people in the audience if you wanted to say something. You two gentlemen, both of you, seem to be interested or have a thought on this, and I have a wireless microphone. Do either one of you want to ask a question or say something to the panel, or anyone else? Yes? Okay, let me walk over there with this.
While you're walking over, I just also wanted to comment. One of the biggest areas of cyber theft right now is in the medical record industry. An electronic medical record on the black market is worth about $50 per record, versus the traditional identity theft of your social security name, your mother's name, date of birth, that type of thing is worth between $1 and $5. So there is a concentrated effort by the criminal element to actually go after patient information, and the technology, unfortunately, has not kept up with the ability for these cyber criminals to gain access to it. We see on an ongoing basis a number of major healthcare organizations whose systems have been breached, and hundreds of thousands of patient records have been stolen. So this is an area that we have to continue to work very diligently around as well.
Larry Isran with Clinical Informatics, and I'm not even sure where to start. I guess we'll start with the technology as a tool, and all tools need processes, and how the processes are dependent upon your environment. And so we have legislation and we have policy that has so much more impact on the healthcare system than the technology ever can. And then to the breaches, I mean, we have millions of patient records being lost, and to Kiran's point about, yes, she could look at that social security number on the piece of paper, but you can only look at 1 or 2. When it's digital, you can collect millions with a keystroke. And so there is, while I agree with you that there's, in some cases, privacy is an illusion, in other cases, we need to find ways to do a combination of both policy and technology, because technology alone will never give us complete privacy. There will always be circumstances, and I fought with CMS for almost 2 years on the National Provider Identifier, because you could, if you were a well-organized criminal, you could spend $1 million on whoever runs the NPI database, pull 800,000 physicians' information, and just do 10 or 20 of them a month to create fake IDs with high credit limits, pull money out, move on to the next, and you'd never be found out. I mean, there are so many ways through policy that has nothing to do with technology where privacy is at risk. In terms of blocking, I think that the concept of blocking is poorly defined. What if a patient doesn't want their information to go? So there are some patients who are on antipsychotics. They don't want their information to go to certain providers. If the patient says, we don't want this information to go, shouldn't the patient have a right to do that? That's different than a health record vendor saying it's going to cost you $17 million to make this one connection to this other organization.
Very different.
But if they say it's $5,000 and it's just a little bit over their cost, is that blocking? I mean, so we have trouble with the definition of information blocking. And I think to the point of the CVS card, I bet you can't take the CVS card to Target and have them pull up all your information. And so the challenge that we have is that it's the same circumstance in healthcare. You might be able to have all your information at a Kaiser and have all the Kaisers talk to each other, but you're not necessarily going to be able to take it to a Mercy, just like you would or wouldn't if you went to Target or to Walgreens or to Rite Aid, because there is a competitive environment. And so the environment has a much bigger impact than the technology does in terms of the data sharing. So there's policy issues that have to be addressed. There's competitive issues that have to be addressed. We have the standards available to share the data, but the challenges are broader. And I'll say one last thing, and so this is where I have a conflict of interest, and that is, so I'm president of a startup, and our focus is on how do we get the patient data to the patient. Because one of the challenges that we face is the first step to change is knowing where you are. And most patients don't know anything about what's in their record. And we also know, well, I should say we don't know, how many records, paper or digital, have errors in them. But I know anecdotally from talking to peers, including physician peers, who say, oh, you know, I looked at my record and it said this and it was completely wrong. And once it's in the record, it gets replicated and distributed, and sometimes it's all over. And the only way we're going to figure out all those errors is if the person who has the greatest interest in making it accurate has a chance to look at those records.
They always say never hand your microphone over, you might not get it back. I'm kidding. Those were all very, very interesting points. And I am getting the 1 minute hook, so it's okay, not your fault. I know, there was a robust discussion today, which is great. Would you like to say something?
Question, if I may. So we do love talking about EMR and policy, don't we? And you know, EMRs are super clunky tools. That's what everyone thinks. Yesterday we had a very informative CMIO panel, and actually they opened my way of thinking, and they said the actual biggest problem is policy around regulation and billing, not the actual clunky tool itself. So I don't know if you have any thoughts on that and how we change the policy and make the doctors' lives easier. I mean, part of it it's from the payer's perspective, but part of it also is, you know, governmental regulation. Thank you.
Absolutely. I think, again, in just two areas, and I'll comment real quick so my colleagues can speak. On the privacy and security side, again, as I mentioned, the Kaiser example, I mean, in their model, they can share information. In some cases, they're restricted because of the privacy and security rules between the different states. And then on telehealth consults as well, too, and the reimbursements for those. Those laws need to change so it's easier for the physicians to deliver telehealth consults and get paid for them.
I think the comment I would make is I definitely do think there is a connection between the payment reform work and the role of technology and innovation. And so I'll give you an example that's not a direct analogy to what you're raising, but I think there is a connection between them. I was with a number of community health centers yesterday in Southern California, and the way community health centers are paid is per visit. It's sort of I won't go into the details of it, it's a payment system that sounds like a number of you are familiar with. Per visit. Yet, as community health centers are trying to be creative about how to better serve their patients, particularly their patients with chronic disease. There's much more they would like to do with technology, with in-home monitoring, even just phone visits with nurse case managers, but they don't get paid if they do that right now, because it has to be an in-the-clinic visit, and not only in the clinic with a certain type of provider. And so there's a discussion happening right now in the state of California between the state and these community health centers about, well, how could we pilot an alternative payment system that frees you up from that, so that the focus can be on doing some of these innovative things, many of which involve technology, when an in-person visit is not actually required. And so I think that's where we just have more work to do to think about as we structure payment and payment reform toward quality and outcomes. Where are there opportunities to couple that with some of the flexibility, I guess, that providers are seeking? And so I take the point.
Pronoy, did you?
I am fine.
He said I'm over this. No, but it was a fantastic discussion. I want to thank all of you. We're forcing them to stick around for a couple more minutes if anybody wanted to have an informal conversation or exchange any information. And so we'll do that right now. Thank you all for coming. It was an early one, but I think we got a lot of really interesting and useful information. I also have 40 more questions, but I am on borrowed time, as we've already known. But thanks so much, and feel free to talk to the panelists and exchange information. And all of you, thank you so much for coming. Really appreciate it. You guys were great.